So good evening, all the faculties and delegates. And I, on the behalf of Corona Remedies Private Limited, I welcome all of you for the Searchlight webinar series 01 on the first trimester bleeding, which is associated with initiated by the Raipur, Bilaspur, Sagar, Katni, Rewa, Singrauli, and Ratlam Ops and Gynae Society. And today it's my pleasure to welcome Dr. Asha Jain ma'am, who is a medical director of Cancer Prevention Relief Society, as well as she is currently a director of SMSA Hospital, Raipur, and elected member of CG Medical Council. And she is a vice president of IMA Chhattisgarh and zonal chair FOXY, Food, Drug and Medico-Surgical Equipment, West Zone. And Madam is a chair mission Pink Health, IMA Raipur, and executive member of ISCCP. Madam, Dr. Asha Jain is the immediate past president of Raipur Ops and Gynae Society.
Mehul, I think they know me, so you can just go to the fields of interest and leave it at that.
Yeah, ma'am. So already you know the Asha ma'am, and ma'am having the interest, a keen interest in the savings of uterus, fetal medicine, Ops and Gynae, ultrasound, critical care, as well as preventive of oncology.
वक्रतुंड महाकाय सूर्यकोटि समप्रभा निर्विघ्नं कुरु मे देवा सर्वकार्येषु सर्वदा।
विघ्नं कुरु मे देव सर्वकार्येषु सर्वदा।
असतो मा सद्गमय तमसो मा ज्योतिर्गमय मृत्युर्मामृतं गमय। ॐ शान्ति शान्ति शान्ति।
Thank you, Mehulji. Would you please stop sharing for a minute? At the outset, I would like to thank all the dignitaries. At the outset, I would like to thank all the dignitaries who agreed to be a part of this maiden effort. I thank Dr. P.K. Shah sir, from whom initially I got interested in ultrasound, and he has been a blessing to me all these years. Dr. Rajendra Singh Pardeshi sir, Abha Singh ma'am, though she is not directly my teacher, but she has had a great deal of influence on my life. Dr. Vidya Thobi, another friend of mine who's going for vice president this year. Our chairpersons, Dr. Tabassum Dalla from President Raipur Society, Dr. Monica Pathak, Secretary Raipur Society, Dr. Sangeeta Sinha, President Foxy Bhilai Society, and our respected speakers who agreed to actually make the spotlight, the searchlight work. So each talk, which is to be only for 8 to 10 minutes, will actually put a searchlight on every bit of the topic. So we have Dr. Nidhi Bajaj, Secretary Katni, speaking on overview and physiological bleeding. Dr. Vandana Gupta, President Katni, speaking on threatened and missed abortion. We have Dr. Padma Shukla, who's the president of Tiva Society, speaking on ectopic and pregnancy of unknown location, and Dr. Rashmi Sharma, the president of Bilaspur Society, speaking on vesicular mole. We have respected panelists, Dr. Kirti Kaura Ma'am, Secretary, Bhilai, Dr. Nidhi Mishra, Past President, Sagar, Dr. Rekha Singhal, Secretary, Rima, Dr. Dolly Mehra, Past President, Ratlam, Dr. Sunita Vadvani, President, Ratlam, and Dr. Pratibha Makhija, who's the Secretary of Bilaspur Society. Dr. Mahesh Prasad has had an emergency in his house. He is the Secretary of Singrauli and may not join. I welcome all of you with folded hands to this webinar, and I would like to introduce our chief guest, Dr. P.K. Shah sir, to give his blessings. May I have the CV, please? Thank you, Dr. Vidya, for joining. Mehul? Dr. P.K. Shah sir, who's the past president of Foxy, is our chief guest. And it is a great privilege and honor for me to introduce him. He actually doesn't need any introduction. Every Foxian knows him. But just as a reminder, he is the professor and unit head, Department of Obstetrics and Gynecology, St. GS Medical College and KEM Hospital, Parel, Mumbai, till 2016. Past dean, Indian College of Medical Ultrasound. Past president, Indian Association of Gynec Endoscopists. Past president, Federation of Obstetrics and Gynecological Societies of India. He is also the past president, Mumbai Society, Association of Full-Time Teachers, KEM Hospital, Indian College of Medical Ultrasound, Imaging Science, ISOPAP, IMAGS, WellStart International. Other than this CV, he is a gentleman, always ready to encourage youngsters. And when I knew him, I was a youngster. Now I have white hair. So over to you, sir, for your words of blessings.
Thank you very much, Asha, for your kind words. First of all, let me congratulate you for starting this Core Connect live webinar. It's nice to see the topic, first trimester bleeding, a very practical thing for each and every obstetrician. Number two, it's so nice that you're involved, office bearers of Raipur, Bhilai, Bilaspur, Sagar, Katni, Ratlam, Rewa, Singrauli, etc. So nice, because what I have seen is that when you don't have these webinars, the smaller society office bearers don't get exposure. And this is the best platform for them to give exposure to all our Foxy members. So thank you very much for having them with us. And it's nice to share this platform with my three friends, Dr. Rajendra Singh Pardesi, Dr. Abha Singh, and Dr. Vidya Thobi. Again, coming back to topic, we selected 4 very important topics, and I'm sure the speakers will do justice to these 4 topics. This is going to be followed by a panel discussion, which is going to be moderated by you. And there are 7 wonders around you, I suppose, out of which one has dropped out. And we'll have a nice time listening to you during the panel. As this is the first webinar of yours and you have started, I wish you all the very best for all your future ventures and keep doing this academic activity all throughout. I think this is required. So nowadays, we have a lot of physical activities going on and physical conferences. People are used to webinars because they don't have to leave their houses. They don't have to travel. They don't have to spend money. So the webinars have reached each and every corner of our country. To continue to do this good work. Wish you all the very best for all your future activities. Thank you very much for having me and making me a part of this program. Thank you.
Thank you so much, sir. Thank you so much for your words of blessings and wisdom and encouragement. So now I would like to have the seat of our guest of honor, please. Pardeshi sir's CV. So our first guest of honor is Dr. Rajendra Singh Pardeshi sir. He is currently the president of AMOGS. He is a great academician presenting many papers and everything. He was faculty in FIGO 2006. He was the past chairperson of Food and Drug Committee, to which I'm aspiring in the future. He also got the Dr. Hansotia Best Committee Award for this committee. He was VP Foxy 2019-20, VP AMOGS 2018-22, and now he's the president. More than this, he's an extremely humble and very, very helping person. Whenever I call him, sir, thodi madad chahiye, he's always there. So I'm delighted to have you with me, sir. Namaskar, and over to you for blessings.
Namaskar. Good afternoon, everybody. Respected Chief Guest, Dr. P.K. Shah, sir, who is my mentor since 1987 when I was in LTMG Sion Hospital. I am proud of his disciple. Just add to biodata to Dr. P.K. Shah, sir, just always to know Dr. P.K. Shah, because of P.K. Shah's, Dr. P.K. Shah's efforts in 2011, now we can do sonography because in his tenure of presidentship, he fought for us and MCI took a decision that any degree in OBGY, DGO, MD or DNB, and they can do sonography. So, sir, salute to you for this. So, our guest of honors, Dr. Abha Singh, Vice President of Vaginal Surgeons of India. Then Dr. Vidya Thobbi, who is now Kasoga President. So first, I wish to congratulate Dr. Asha Jain, Program Director, for organizing such an academic feast and with practical tips on first trimester bleeding. It's really a power-packed program of academics with expert faculties like Dr. Nidhi Bajaj, Vandana Gupta, Dr. Padma Shukla, Dr. Rashmi Sharma, Dr. Asha Jain, Dr. Dolly Mehra, Dr. Sangeeta Sinha, Dr. Tabassum, Dr. Monica, and all panelists. I wish every success to Dr. Vidya Thobbi and Dr. Asha Jain for their future endeavor in Foxy. Dr. Jain is aspiring for Food and Drugs Committee. Just I wish to tell you, even I was heading that committee, and even Dr. Vidya Thobbi was also heading this committee. So best wishes. I wish every success to this webinar. Thank you so much.
Thank you, sir. Thanks a lot. And Mehul, Abha Singh ma'am, CV. I'm really grateful to Madam Dr. Abha Singh, who's the former Vice Chancellor, Pandit DD University of Medical Sciences, Professor and ex-Dean, Pandit Jawaharlal Nehru Medical College, Raipur, for agreeing to grace my very first webinar, which I'm holding under the name of Searchlight. So she is MBBS, MS, FICS, FICOG. Fields of interest are infertility, medical disorders of pregnancy, AUB, and vaginal surgery. Presently, she is the Vice President of Society of Vaginal Surgeons of India. She is the patron of Indian Menopause Society, Indian Fertility Society, Indian Society of Assisted Reproduction, Raipur, and of Raipur Obstetric Gynec Society. She is the patron because she is the one who actually pushes everyone, go ahead, go ahead. Even when I told her that I'm going to go for this committee, she said, we are behind you, you please go ahead. She has so many awards, CM's Trophy for Meritorious Service, Padma Shri S.K. Mukherjee Award, Best Paper in Oncology in AICOG, Medical Icon by Times of India Group, ISAR Lifetime Achievement Award, MS Signature Award, and she has presented more than 110 papers in national and international conferences. She has written a book on obstetric emergencies and added more than 82 chapters in various books. And she has conducted live workshop in NDDVH, B-Lynch operation, programmed labor and colposcopy. More than this, when she was the dean and I became the president Raipur Obstetric Gynec Society for the first time. Madam, students came to visit her, and the regard they had for her was actually eye-opening for me. That so much of love they actually had for her. So that sort of gets transferred. We all love you, ma'am, and I'm here waiting for your blessings.
Thank you very much, Asha, for your very, very kind words. It's good to hear about yourself sometimes. First of all, my namaskar to our chief guest, Dr. P.K. Shah. Always he has been a guidance behind all our previous ventures as when I was president in Raipur Obstetric Gynae Society. And there have been so many lectures of his I have attended throughout my different AICOG conferences, where I think whatever I know about ultrasound, I remember what he says and in which lecture he has said. Thank you, Shah sir, for always being there. Very happy to share this platform with the previous Food and Drug Committee Chairperson, Dr. Pardesi. Lots of regards to you, sir. Also, Dr. Vidya Thobi, madam, wishing you all the best for your future venture. And Asha, what should I say? Thank you so much for making me part in your, especially the first episode of this Searchlight. First of all, I have loved the name Searchlight. And together, I would like to be with you in your journey. And I'm sure I always think there are 3 P's. One is not PK Shah sir, but one is patience. Second is persistence. And third is perspiration. These 3, I think, form an unbeatable combination for the road to success. And may you have all the success you wish for. And whenever you require, I'm always there behind you in anything, anytime, whenever you need me. And I think today's topics are very interesting and very basic, and just waiting to hear from all of you. Thank you once again, and wishing you the very, very best for this chairperson of Foods and Drugs Committee. And take all the necessary tips from Dr. Pardesi, because you will, I'm sure under your guidance, we should receive another award for this committee. All the best.
Thank you
so much.
Thanks a lot. Thanks a lot. Those words are really precious, and you will not find me short on perspiration, ma'am.
Glad to know.
So we have with us Dr. Vidya Thobi, our next guest of honor. She is the professor and HOD Gynae, Al Amin Medical College, Vijaypura. She is the president of KASOGA, that is all Karnataka Societies of Obstetrics and Gynecology in 2023. She was the past chairperson of Food, Drug and Medical Surgical Equipment Committee 2018 to 2020. She is the national corresponding editor, Jogi, organizing chairperson KASOGA 2016, treasurer KASOGA, EC member KCS Agai, academic council member, Women's University Vijaypura, Al Amin Journal of Medical Sciences editorial board, UG and PG exam paper setter and PG guide. She has been teaching for 30 years. She is on the advisory faculty of both Rajiv Gandhi University of Health and Sciences, and she is going for vice president South Zone this year. So, Dr. Vidya, I'm really glad that you have agreed to join my webinar, the very first one, though you are in a train. So I'll be happy to listen to a few words of blessings and guidance from you.
Thank you, Asha, for those kind words, and I must congratulate for your perseverance. And this Searchlight really will give some insights to every one of us. It is always a proud privilege to be amongst the very great audience as well as the leaders of Oxy today. Dr. P.K. Shah, whom I admire the most, Always I seek guidance from him, Dr. Pardesi, and the senior most faculty and the guest of honor, Dr. Abha Singh. Always I love to listen to her many times. You have gathered many stalwarts who will be talking, and you are focusing mainly on Raipur, Bhilai, Bilaspur, Sagar, Katni, Rewa, Ratlam, and Singrauli OBGYN societies. And it is really a great topic you have chosen today. That is first trimester bleeding, where always we have dilemmas in management, and the patients are also very curious to know about the outcome, and the ultrasound plays a very important role. So Dr. P.K. Shah sir is there, and he may give at the end some expert comments on the management also. And I'm very pleased to see our Dr. Tabassum Della, who was very much a student of my college, and she has rose to a president of your society, that is Raipur OBGYN Society. Dr. Monica, Dr. Sangeeta. It is really glad to see all others, because I cannot take everybody's name, but I'm really closely associated with them virtually. Many times I have come across. And the efforts Dr. Asha Jain has done in many ways. I know her personally. She's so academically sound and spiritually also enlightened human being. I must say human being, because I know how close she is with me also. I wish her all the best in her endeavors, and we will all support her for her candidature for Chairperson, Food, Drugs and Medical Surgical Equipment Committee. I also acknowledge the guidance by Dr. Rajendra Singh Pardesi, who has always been by the side of me whenever I put one step ahead in Foxy. So thank you very much, Dr. Rajendra Singh Pardesi and Dr. P.K. Shah sir, for guiding me in my various activities in Foxy. So thank you. I'm also eager to listen to all of you. Maybe I am traveling, so may be network issues, but definitely at the end, I would love to listen to the outcome of this very first endeavor by Dr. Asha Jain. All the best, Asha. Thank you very much.
Thank you. So I thank all my guests of honor and our chief guests for being here. I understand you're very busy. If you wish to leave, you may, but I would be really gratified if you would actually just sit in, and wherever we are going wrong, wherever we need guidance, to guide us right through the webinar, because our topics are very short and very focused. So anywhere you feel that you need to speak up, you are most welcome to just join in anytime. It's your webinar. And I thank Corona Remedies for being with me through this venture and agreeing to be part of my academic programs in the coming year. So thank you, Corona, and thank you, Mehul in particular. You've been like a rock all the time. And now may I have the CVs of the chairpersons, please? So all three chairpersons are very well known in Chhattisgarh, but for the others who are not in Chhattisgarh, I would really like to introduce them. May I have the CVs? So this is our dear Tabassum. She is the president of Raipur Obstetric Gynec Society, vice president IMA Raipur. She has a diploma in minimum access surgery, diploma in ART. She is director of Jubesta Hospital. She has a Foxy recognized ultrasound training center. She is a member of a lot of committees, and more than everything else, she is very dynamic and has a knack of pulling people together to get work done. So welcome, Dr. Tabassum.
Thank you, Asha ma'am.
We have Dr. Monica Pathak, who's currently the secretary of Raipur Society, and she's been so for last 2 years, and before that she was treasurer for 4 years. She is the consultant and director of Sai Sushruta Hospital. She is the daughter of my teacher, Dr. Shobha Sharma ma'am. So many of us who are senior gynecologists have learned under her. Shobha Sharma ma'am, She's a laparoscopic surgeon. She's specially trained in obstetric and gynec ultrasound. She's an ISCCP trained colposcopist, and there are many positions. She's helped organize a lot of conferences, a very hard worker. Then we have Sangeeta Sinha. She is the president of Oxy Bhilai. She is in charge of Revival Medical Center as a director. She is Durg Women's Wing India IMA chairperson, IMA AMS CG secretary, clinical secretary of Indian Medical Association Durg, vice president Foxy Bhilai. In 2017 and 19, chapter secretary IFS 2017 to 19, and she has ovum pickup needles assisted reproductive technologies and lab sciences award and publications are there. She is another person who is very devoted to assisted reproduction and also to academics. She puts everyone together. She tries to keep all Chhattisgarh together. So thank you, Sangeeta, for agreeing to be here and being a support to me. So
Good
with
afternoon,
that,
ma'am.
I hand over to the chairpersons to introduce the speakers and take the program forward. So over to you, respected chairpersons.
Thank you, ma'am. Thank you, Asha, ma'am. And good afternoon, everyone, respected faculties. Dr. P.K. Sasa, can you share the off the screen, please, Mehul? So good afternoon, all respected chairpersons, the guest of honor, the chief guest, Dr. P.K. Sasa, Dr. Pardesi sir, Dr. Abha Singh, ma'am. And very good afternoon to Asha Jain, ma'am, for starting the Searchlight. It's really the need of the hour. So with this platform, we can connect. I congratulate you for this. And without wasting the time, we will start the talk because it's very important. The first trimester bleeding. And I will request Mehul to share the CV of Dr. Nidhi Bajaj, who is taking the first talk. Fetin and Ms. Trabo, who is taking the first talk. Overview and physiological bleeding. May I have the CV, please? Yeah, Dr. Nidhi Bajaj is the director of Spurs Multi-Speciality Hospital, Katni. She's the secretary of Katni Obs and Gynae Society. She's the member from CGMC Nagpur. Has a publication of term uterus in complicated ventral hernia. Membership of professional bodies, Foxy IMA, PCOS Society. She had also got the Young Talent Award at the West Geneva Foxy in October 2022. Lots of presentation in laparoscopic birth chronic perineal tear. And so there are lots of, I think, academic activities over there. Over to you, Dr. Nidhi Bajaj, for your talk, overview and physiological bleeding.
Thank you, ma'am, for the kind introduction. On the onset, good evening, everyone. Thank you, Dr. Asha Jain, ma'am, for providing an opportunity. If it would have been a physical CME, I would have shown the shivering I'm having because it is less known. I was one of the students of Dr. P.K. Shah, sir. So speaking in front of your teacher, how it feels, I just cannot show the palpitation right now I'm having. I'm sincerely thankful to Dr. Asha Jain, ma'am, for including our smaller society, Katni Obstetric Gynec Society. And a special thanks to Dr. Asha Thubi, ma'am, our chairpersons, Dr. and chief guest and guest of honor, Dr. Rajesh Pardesi, sir, Dr. Abha Singh, ma'am, to all. Can I share my screen now, ma'am? Am I audible, ma'am? Is it like...
Yes, you are audible. Very much audible. And please share your screen. Mehul, please make everybody co-host.
Okay, ma'am.
They have to share screen.
No, they can share, ma'am, without co-host. No issue.
Okay.
But I am making.
Is it okay, ma'am? Is it visible?
No.
Nidhi, you need to open that first and then start sharing. You need to stop sharing right now.
Just
Nidhi, can you hear us?
Yes, ma'am.
So stop sharing, open the presentation, and then share. Yeah.
I'll
Open the
stop
presentation
sharing.
first.
Yeah, I've opened it.
Now,
Then share.
click
Now share it.
Yes. Please make it full screen. Slideshow. On the top, there is slideshow.
Here, yeah, 57% is there. So just beside the 57%.
Here, this one.
Is it
This
okay?
hourglass
Now
has
is
to
it
be
visible?
clicked. Click the hourglass.
Ma'am, I clicked. On my screen, it is showing the full screen.
You just go ahead. We have only 10 minutes, so just go ahead.
So, topic for today is overview of first trimester bleeding. So, the incidence of first trimester bleeding is ranging from 20 to 40%. And it is mostly the maternal blood. That is because of the destruction of the vessels of decidua, or it could be a discrete cervical or a vaginal lesion.
Slides are
that
not
is
changing.
bleeding.
Slides are not changing.
Just press the escape button.
Escape. Escape on your computer.
Yeah.
Okay.
Click that. This hourglass needs to be clicked.
Is it visible now? Ma'am, I clicked it.
Yes.
Is
Yes,
it visible now, ma'am?
It was. Then
It was moving, yes.
Is it now?
No.
Resume share.
The blank screen.
Nidhi? Dr. Nidhi?
Yes, ma'am.
You send me the presentation on WhatsApp. Stop sharing and send it to me. Yeah, it's there now.
Again go.
There now.
Paper हटा दो.
Ma'am, we'll do one thing. Well,
You send the presentation to Asha, ma'am.
yes, ma'am.
Go ahead with this. You can go on talking.
Okay.
You will have to click the left side bar.
Just a minute, ma'am. It is showing
Yes, ma'am.
on my screen, ma'am.
You just go ahead.
Is
No,
it
it's
not
not
visible?
yet. No.
Ma'am, don't do
No,
full
it's
screen.
gone
You
again.
just go ahead with the normal presentation.
Okay. Is it visible now?
No.
It's better you share all these slides with Asha and Madam to WhatsApp so that she can keep on changing as per your.
Yes, ma'am. Ma'am, that I have to share through.
Send it on mail to me. Send it on mail. Nidhi, you stop sharing. We'll take the next lecture and then we'll take yours.
Okay. Stop share. Ma'am, I did a stop sharing now. Just a minute, ma'am. I will do. Okay. Ma'am, is it visible now?
Yes.
Yeah. Now it's fine.
It's fine.
Yeah.
Can it be seen?
Yes.
Okay, so the incidence of vaginal bleed is usually 20 to 40% in the first trimester, and mostly the cause is the maternal blood. And
yes.
Usually, the etiology, the causes are related to the pregnancy, or it could be associated with the pregnancy. So the causes related to the pregnancy are abortions, the ectopic gestations, the molar pregnancy, implantational bleeding, or it could be a vanishing twin. So associated with the pregnancy could be a pre-existing disorders exhibited during the pregnancy, thrombophilias, like things, or cervical lesion, vascular lesions like vascular erosions, polyps, ruptured varicose veins, malignancies, cervicovaginitis, or trauma due to the intercourse. Cervical polyps, erosions, and malignancies can be seen. The first abortion, 95% of the first trimester bleeding is due to the abortions. The basic pathology is hemorrhage occurs in the decidua bacillus. There's a necrotic changes occurs adjacent to the tissues near the bleeding. There's a detachment of the conceptors. And with this pathology, the uterine contractions get stimulated and resulting in the expulsion of the fetus or the product of conception. Usually, abortions are categorized into two, can be spontaneous or induced ones. The induced ones are the medical termination pregnancy or the unsafe abortions like a septic abortions. Spontaneous abortions can be recurrent or the isolated. They both are divided into isolated ones like threatened abortions, in which there's just a slight bleeding or pain, but still the pregnancy is viable. The inevitable abortion is a place where the product of conception or is a process of the abortion are about to be delivered. The complete abortion is where the whole the products have been expelled already and the internal os is closed. In incomplete abortion, the products are expelled, but the retained products are still there and the os is open. Missed abortion, when their fetal pole is present or the yolk sac is present, but the heartbeat that was earlier there is now not present. Septic abortions are with the infection or raised WBC counts. So in the threatened abortion, we only have a retroplacental bleed with just spotting or a minimal bleeding. But product of conception, the fetus is viable and the cardiac activity is present. In incomplete abortion, as we can see, there is a opened external and internal os, and the patient is keep on bleeding. In inevitable abortion, the product is about to be expelled, is in a process of expulsion, and missed abortion, the cardiac activity is not present. The external or internal os may be closed or may be open. The next common cause is a ectopic pregnancy. First, we have seen abortion. Second is ectopic pregnancies. They incidence range from 1:25 to 1:250. The average is around 1 in 100 normal pregnancies. The incidence in today's world is increasing because of the increased assisted reproductive techniques, late marriages, late childhood bearing, pelvic inflammations, use of IUCDs, and tubal surgeries. It is important to know that recurrence rate is about 15% after the first ectopic, and it goes higher up to 25% in previously 2 ectopics. Ectopics are classified according to the location of the...
Ectopic is a separate topic.
Yes, just giving an overview of all the topics. Okay. So the third is a molar pregnancy. A molar pregnancy is a problem of abnormal placentation. There's a partial degenerative and a partial proliferative changes in young chorionic villi. Usually the hereditary form mole or a partial moles comes under gestational trophoblastic diseases. They are further classified into invasive moles, hereditary form mole that can be complete or incomplete, choriocarcinoma, placental site trophoblastic tumors, and WHO gave a classification of choriocarcinoma into a metastatic and a non-metastatic ones. In a complete mole, it is to be remembered that there's a massive enlargement of the edematous villi that gives a classic grape-like appearance of the placenta and lack of embryonic tissue with a snowstorm appearance on the ultrasound. While a partial mole includes multiple small stick lesions in placenta with viable fetus And the diagnostic criteria is the AP diameter of GSAC ratio is more than 1.5. We can see the classic grape-like appearance and the snowstorm appearance. There, on a color Doppler scan, we can see a molar pregnancy. In a partial mole, there is a cystic placenta with a growth retarded fetus that can be seen. So the basic difference between the two, there will be a fetus in the partial mole, there will be no fetus in the partial mole. The karyotype of a partial mole is with 69. There is a 46XX in a complete mole. Focal edematous villi are present, while in complete mole, there is a diffuse involvement of all the villi. Uterine size is a smaller for date in a partial mole. In a complete mole, it will be a more larger for the date. Medical complications are more with partial mole and are less with partial mole and more with a complete mole. The progression to the trophoblastic neoplasia is more in a complete molar pregnancies ranging up to 20%. Now, the vanishing twin. Vanishing twin syndrome is considered when one set of twins or multiple embryos die in utero, disappear or get reabsorbed partially or entirely, with the outcome of spontaneous reduction of multi-fetus pregnancy to a singleton pregnancy. It is increased in with maternal age, with chromosomal abnormalities, increased twin, with ARTs, with increased incidences of multiple gestations, and with genetic or teratogenic effects. As we can see in the picture, the one fetus is viable, while fetus 1 and 2 are the vanishing twins. Now, the physiological bleeding or the implantation bleeding, small amount of spotting or the bleeding 10 to 14 days after fertilization, probably at the time of missed menstrual period, is considered as an implantation bleeding. It is considered that implantation of the fertilized egg in a decidua is the reason for this bleeding. It is usually the spotting with very less pain in abdomen. Although this hypothesis is being questioned, it is a diagnosis of exclusion and no intervention is required in this. Usually, this implantation bleeding is associated with nausea, light cramps, frequent urination. There, it may stay for 1 or 2 days, and usually the color of blood is light pink to brown, with pregnancy test will be positive. As compared to the normal menstrual cycle, which may long up to 4 to 7 days, it is brighter colored and the flow is more, and the pregnancy test is negative. Another causes for first trimester bleeding are vaginitis, trauma, tumor, warts, polyp or fibroids. The diagnosis is by perspectival examination that gives a very much insight of the pathology going on. Additional tests may be required like vaginal swab, cytology, biopsy of the lesion, and ultrasound is a criteria for the choice. So for the diagnosis, we need a history. A proper history of the vaginal bleed should be taken, a slight or it is a bright red. It could be a fleshy mass or foul smelling or discharge in the case of septic abortion. It could be passage of the grape-like vesicles in case of molar pregnancy, sanguineous or dark colored in the case of inevitable abortion, or white currant or red currant jelly in case of ectopics. The examinations, vitals per abdomen, per speculum, and per vaginal examination is required. Investigations like complete blood count of the patient, ABO, RH typing is important. Thyroid profile is important to be done in cases of the molar pregnancy. Specifically, fetal echo and the cardiac evaluation of the molar pregnancy patient should be done. And a sequential beta HCG titer will give us a more light on the same. Ultrasound makes the cornerstone for the diagnosis of this. This is the most information and informative. Making it an intrauterine or extrauterine, ruling out the heterotropic pregnancies, viable, non-viable, gestational tuboplastic neoplasias, loss of one fetus or multiple gestation, all can be made out on a transvaginal sonographies. Few terminologies are being introduced nowadays, such as pregnancy of unknown location. It should replace the pregnancy of the indeterminate location position, the positive pregnancy test, but there is no sign of intrauterine or extrauterine pregnancy or no retained product of conceptions comes under the terminology of pregnancy of unknown location, PUL. And PUV is a terminology given nowadays for intrauterine gestation of 20 mm diameter with mean diameter with no obvious yolk sac or fetus pole seen, or a fetus pole of 6 mm crown lump length with no obvious fetal heart rate, and the repeat scan even after 1 week is the same, it is given to pregnancy of uncertain viability or PUV. The sonographic criteria are the cervical length of more than CRL of more than 7 mm with no heartbeat, mean sac diameter more than 5 cm with no embryo. In such cases, repeat scan after 10 days or 11 days is done. If the heartbeat is seen, the pregnancy is considered as viable. If the heartbeat is not seen, a repeat scan after 2 weeks is advised. And if in the same case, no heartbeat is present, it is labeled as a missed abortion. Transabdominal scan is done to rule out the ectopics and the free fluids. At last, careful history taking, local examination in good light will help a lot, excluding the most common of non-obstetrical causes of bleeding. Transvaginal scan holds the gold standard to know the viability of the status of the embryo. It helps in diagnosis of all the possible obstetrical causes except due to karyotyping defects in embryo. It may give a snapshot and may have a limited value. If no local cause is found, case need to be investigated for bleeding disorders by tests such as BT, CT, clot retraction, platelet count, and thrombin time. All women should have their ABO grouping if Rh negative NTD therapy in low dose of 100 microgram in tube given in 24 hours of first bleeding episode. Thank you.
Thank you, Dr. Nidhi Bajaj.
Yes.
It was a
Sorry
very
for the
nice overview.
initial wastage of time, ma'am.
No, that
It's
is
okay.
absolutely fine. It is raining heavily here. I think is it raining there also?
No, it's not raining in Bhilai, Tabassum.
Ma'am, it's raining
It is
very
raining
heavily.
in Raipur.
Mhm.
Yeah.
Raipur is
So a
raining.
very good overview of pregnancy, early pregnancy bleeding, because whenever one patient comes to us and then we say that I've got a bleeding, all the battery of the causes what you have mentioned come to our mind, back of mind. So that should always be there. And apart from that, what, as you said, that physiological bleeding in pregnancy is also important. We must differentiate between this physiological bleeding or a pathological bleeding. And this physiological bleeding, any physiological bleeding, we should need not start all the sustained injections and all those progesterones. So it's very important to know the physiological causes also of bleeding and also the reasons of bleeding. So thank you very much for a very nice overview of early pregnancy bleeding.
Shah sir wants to say something.
Yeah.
No. Okay. Proceed.
So coming to the next session, it was a wonderful overview by Nidhi. So coming, as we are already short of time, I'll be inviting our next speaker, Dr. Vandana Gupta, to in this Searchlight series to throw some light on threatened and missed abortion, and as well as of wanting, as well as uncertain viability situations. Can we have a CV of Vandana Gupta, ma'am? Yeah. Welcome, Dr. Vandana Gupta. Ma'am, she has done DGO from KGMC Lucknow, and she is working obstetrician and gynecologist in Katni for last 22 years. She is owner and director of Om Shanti Maternity Hospital, Katni. At present, she is president of Katni Obs and Gynec Society, founder and past vice president of Katni Obs and Gynec Society, and also vice president of Obs and of IMA Katni. We welcome you, ma'am.
Monica, I would like to add that she was very reluctant. I pulled her into it and she's agreed.
So nice. Madam, there is nothing to be reluctant about. We are all in same boat, and it's a great opportunity that Asha Jain Madam has given to us, so that all the small societies we participate, and that's how we get connected with each other.
Very true.
So thank you. Good evening, everyone. Lord Secretary Ganesh Chaturthi to all of you. God, Lord
Dr. Vandana, आपकी स्क्रीन पे एनेबल एडिटिंग दिख रहा है ना, ऊपर टॉप पे देखिए, उसको क्लिक करिए, तब ये शेयर होगा. make that enable editing, right side. ये देखिए यहाँ पर protected लिखा है ना, say make that enable editing.
Okay, ma'am.
Yes.
Ma'am, you have shared a Zoom screen. You just stop sharing. Okay.
Yeah.
So good evening, everyone.
Yeah.
All those this webinar, guest of honor, Dr. Rajan Singh sir, Dr. Amar Singh ma'am, and Dr. Vidya ma'am. So thank you, Dr. Ahmed and madam, for making me part of this wonderful Searchlight webinar. And thank you, Chairperson, for nice introduction. So I am starting with a case. One day I was sitting in my OPD. A patient came to me, priming gravida, married for 1 year, and 2-month amenorrhea and slight bleeding per vagina, and very slight pain in lower abdomen for last 2 days. So I took the history, and there is spontaneous conception. And in menstrual history, there is a slight delay period or cycle of 35 to 45 days. And
your voice is not very clear, Dr. Vandana. सामने देख के बोलिए आप, please.
Okay, ma'am. Okay, ma'am.
This is how you have to speak.
Okay,
we
ma'am.
cannot hear you well.
Okay. So I examined the patient. Her vitals were stable, and on clinical examination, PS examination, there were no any local pathology like cervical polyp and cervical erosion, and trauma, and no vaginitis. So and the uterus was bulky and soft. So I advised for investigation and advice for investigations, sonography. So
Your
I did
slides are not moving. Your slides are not moving. They are not full screen.
Okay, ma'am.
Ma'am, first you stop the sharing, then again select this slide, share this slide, and then after you go for the full screen.
Should I start?
Ma'am, it's not full screen. We can start. It's moving.
So what I do?
Mehul, you can.
Can you help her, Mehul?
Yes, ma'am. Ma'am, what happened, ma'am? You have already make it full screen before sharing. That's why this problem happens. You just first of all you stop share this slide, and in your laptop also the full screen is already open. So you press the escape button. And come back to the normal view of the slide.
Okay.
It should not full screen in your laptop also, ma'am.
Okay.
Okay, then you share. This normal view only you share.
Mehul, you didn't have this presentation?
Yes, ma'am, you can send.
नहीं, आपके पास नहीं है मेहुल इनका
ना,
presentation,
ना,
madam?
मेरे पास no, no, no.
Asha ma'am.
शेयर करना है ना, और वो पूरी स्क्रीन में शेयर करती है। शेयर स्क्रीन है ये स्लाइड। ये वाइट उसकी था ना, लेस पता नहीं वाइट बोर्ड वहाँ दिखाने लगा, पहले दिख रही थी स्लाइड अभी पर बहुत दिख गया होगा।
Asha Jain, ma'am, can we go ahead with the third talk?
Yeah, that's why I heard this.
Please go on with the third talk.
Third
Vandana
talk,
ji,
yeah.
आप अपना ईमेल मुझे प्लीज ईमेल कर दीजिए, मैं अपना
मैंने
ईमेल
आपको
आईडी आपको दे रही हूँ।
व्हाट्सएप में भेजा हुआ है आशा मैम, मैं आपको व्हाट्सएप में भेजा हुआ है।
ठीक है, मैं अभी चेक कर रही हूँ, तो फिर मैं 1 मिनट में रन कर दूंगी।
जी जी,
1 सेकेंड।
Okay. I think, ma'am, Asha ma'am, really you think a lot and put so much of effort in naming any, be it a conference or be it a series, like Searchlight is really a very
now
well
this-
chosen title for this series.
So, Dr. Vanna, you may go on now. Requesting
Yeah.
everyone, please send me your presentation so I will manage.
मैंने भेज दिया मैम आपको।
Yes,
So,
now it is visible.
Okay, Dr. Vandana, please go on. सामने देख के बोलिएगा अच्छे से, जोर से।
अच्छा मैम, आपने डाला है ये सीवी, आप साइड आगे बढ़ाएंगे।
हाँ, आप नेक्स्ट बोलते जाइएगा मैम, आशा जैन मैडम वहां से चेंज कर देंगी।
Clinically, it's a case of threatened abortion. I advise for sonography. So threatened abortion is defined as is bleeding in early pregnancy up to 20.
मैम सामने देख के जोर से बोलिए, आवाज आपके माइक से ठीक से नहीं आ रही है।
With a closed cervix, So it's a case of threatened abortion, and the main causes of threatened abortions main causes of threatened abortions are maternal age and chromosomal abnormality, and the less common causes are Mendelian and polygenic multiple etiology, nuclear defect, and the thyroid abnormality, and the uncontrolled diabetes mellitus anomaly, and pathological abnormality like and lesions, neuromyomas, Mullerian fusion defects, cervical insufficiency, and other causes. In India, one of the
पदना जी कुछ भी सुनाई नहीं दे रहा है.
are older mothers in
मैम लैपटॉप को थोड़ा पास कर लीजिए और कीप इट अप, थोड़ा और क्लोज कर लीजिए.
ओके मैम.
एक बुक के ऊपर रख लीजिए मैम.
मैम कंप्यूटर का वर्क बताना होगा.
So जी, after I advise for ultrasonography. In ultrasonography, there is, ma'am, slide आगे please. So threatened abortion is the most complication in the first half of pregnancy, and its incidence varies between 20 to 25%, and miscarriage is 2.6 times as likely, and the 17% of cases are expected to present complication later in pregnancy. So next slide, please. So the etiology for threatened abortion: embryonic abnormalities, maternal factors, anatomical factors, endocrine factors, infectious factors, the immunological factors. So next slide, please. The clinical features in my patient, pregnant, bleeding per vagina and pain, a very slight pain in abdomen. Next slide. So investigation, blood investigation, mainly CBC and the complete blood count, and blood grouping and RH typing, and T3, T4, TSS, thyroid, and random blood sugar, and other like beta SCG advised, and urine routine microscopic examination done. As already I told, the pelvic examination, no local pathology, and uterus was bulky and soft. And in ultrasonography, next slide, please. In ultrasonography, there are two well-defined gestational sacs, and there is two yolk sacs and two fetal, two embryonic embryo seen. And in one embryo, there was fetal cardiac present. But in second embryo, the cardiac activity was doubtful. So I advise for repeat ultrasonography after 15 days. And in this, with these, sonography can usually differentiate between an intrauterine pregnancy, viable or not viable, and a molar pregnancy or an inevitable abortion. So the pregnancy in this patient, one patient is one fetus is normal, and the CRL was more than 7 mm. Second fetus, the CRL was less less than 7 mm. So the first fetus, so it's the case of threatened abortion and with the pregnancy of unknown, uncertain viability. So the pregnancy of uncertain viability, in this case, as Dr. Nidhi told, if CRL is more than 7, and the gestational size is more than 25 mm. So if CRL, so it's a case of if there is gestational sac is more than 25 mm and there is no fetal cardiac activity and there is no fetal pulse, so it's a case of pregnancy of uncertain viability. So in this case, fetal is for CRL with no obvious fetal heart. Next slide, please. So the with this ultrasonography, the biomarkers are should be done. So serum progesterone value is 25 nanogram per ml. The viable pregnancy in about 95% cases. If serum beta SCG level is 20 nanogram per ml or more, it's the viable pregnancy. To assess the level of fetal memory by this beta SCG level. Next slide. So adverse prognostic factors in cases of threatened abortion: a large empty gestational sac, discrepancy of gestational sac in round to rump length, and fetal bradycardia or absence of fetal heart activity, advanced maternal age, history of recurrent pregnancy losses, and there is maternal serum progesterone is less than 25 nanogram per ml, and a lower maternal serum beta SCG. adverse prognostic factor in cases of the complication. These fetuses are at increased risk of intrauterine growth retardation, preterm delivery, low birth weight, and perinatal death. And maternal risk includes antepartum hemorrhage and manual removal of the placenta and cesarean delivery. Next slide. So the management of threatened abortion is bed rest and paracetamol for pain in abdomen, and the progesterone therapy, SCG therapy, and the tocolytic agents, mainly in second trimester. So next slide, please. There is insufficient evidence of high quality that support a policy of bed rest in order to prevent miscarriage in women with confirmed fetal viability and vaginal bleeding in first half of pregnancy. So the bed rest with restricted activity should be advised. Next slide. So the progesterone therapy, we all are using progesterone in threatened abortion. The oral micronized progesterone 200 milligram OD or BD, and the vaginal progesterone suppository 25 milligram OD or BD, and the progesterone vaginal gel 100 milligram to or thrice per day, and the intramuscular progesterone injection in oil given as 50 milligram per day, or we are also given injection hydroxyprogesterone 500 milligram or in first trimester. Next slide. So use of progesterone is effective in the treatment of threatened miscarriage with no evidence of increased risk of pregnancy-induced hypertension or antepartum hemorrhage as harmful effects to the mother, nor increased occurrence of congenital deformity on the newborn. However, the analysis was limited by the small number and the poor methodological quality of analysis and the small number of participants, which is the power of meta-analysis, and hence of this conclusion. Next slide. The current evidence of, does not support the routine use of SCG in the treatment of threatened abortion. So next slide. So in Rh negative patient, as Dr. Nidhi told, anti-D immunoglobulin should be given. The next slide. NTD, so in my case, the bleeding is stopped after giving this treatment, but the sonography was repeated after about 10 days. So there is no fetal activity in the one twin, and the CRL was still less than 7 mm. And in second twins, the CRL was about 8 mm, and the gestational is about 8 weeks around. So it's a case, so there is demise of in one twin in this pregnancy. So the demise of, so introduction, epidemiology, etiology, and the complication and management in conclusion. So next slide. So introduction, single intrauterine fetal death rate in multiple pregnancy is significantly higher than that in singleton, and the risk increases with the number of fetuses. Next slide. Loss of twin during the first trimester is not an uncommon event. This is vanishing twin, and Dr. Nidhi told something about vanishing twin. So opinions divided as to the risk of development defects when there is fetal demise in the first trimester. Some data are suggestive of a growth anomaly where the other excludes such possibility. So most studies suggest no association with adverse perinatal outcome for the surviving twin. Intrauterine fetal device in the second and third trimester is less common and is more likely to be associated with complications for the surviving twin. And the so single fetal demise complicates about 2.5% to 5% as compared to 0.3% to 0.6% in singleton and 4.3% with the triplet pregnancy, and 3-4-fold better in monochorionic than dichorionic pregnancy. And regardless of the chorionicity, none of these complications occur following single fetal demise in the first trimester. Next slide, please. So the etiology may be spontaneous or heterogenic, twin-to-twin transfusion syndrome, congenital anomalies, placental insufficiency, abnormal cord insertion more in monoamniotic, and intrauterine infection, maternal medical condition, intrauterine growth register, and more in DCTA. Next slide. So, placental abruption, blunt injury, umbilical vein thrombosis, chorioamnionitis, twin reverse perfusion, discordant twin, and the fetal reduction. They are also for this for twin demise. Next slide. So vanishing twin as the term that has been used to describe the spontaneous loss of a twin during the first trimester. Around 23% of twin pregnancy diagnosed by ultrasound at 6 week gestation will be singleton pregnancies by 12 weeks. And the bleeding or mild cramping may be noticed, but there are no longer term implications for the pregnancy. And the grief for the lost twin may be significantly, especially in an IVF pregnancies. So next slide. Maternal medical conditions are also responsible. So the preeclampsia may result in the loss of one twin only. Indeed, loss of the twin is often associated with a short-term improvement in the condition. And selective fetal growth restriction, particularly of the response type 2 and 3 variant, and accounts for significant numbers of fetal deaths in the monochorionic diamniotic twins. Next slide. So the fetal reduction in the congenital anomalies. Fetal reduction may be a consequence of either selective or multi-fetal pregnancy reduction, and the former is performed for a fetal abnormality, and the latter may be performed either because it is deemed medically unsafe to proceed with a twin pregnancy, and the fetal congenital anomaly is much more frequent in monochorionic twins than either dichorionic twins or singleton, especially cardiac and neurological anomalies. Account for a large proportion of monochorionic diamniotic single twin deaths, and the most monochorionic twins, although monozygotic, are discordant for fetal abnormalities. Next slide. Monochorionic diamniotic twins, the twin transfusions accounts for at least 50% of all single MCDA twin deaths. And even with extensive and careful surveillance, the risk of sudden fetal death in the first trimester in these pregnancies is 1.2% to 6%. If the laser treatment has been successful, no risk of subsequent injury to the survivor, but there may be concern about a pre-existing insult to the fetus. So next slide.
I think, this is not first trimester, Dr. Vandana.
Dr. G, ma'am.
This is not first trimester. So I think we need to
coagulopathy and
move that and move only to the first trimester.
Okay, ma'am.
So we
the
are not
management
doing this. It's not the whole thing. So
okay, ma'am.
You can just.
So thank you very much, madam. So conclusion, the severity of a single fetal death in a twin pregnancy depend on the gestation age and chorionicity, and death in the late second or third trimester is associated with significant morbidity and mortality in the surviving twin. And therefore, all twin pregnancies with one dead fetus should be managed in tertiary referral centers with sufficient neonatal support, and a management plan should be individualized. Intensive fetal surveillance is required in the determination of chorionicity should be done early in the pregnancy. So proper care and management is always. So thank you, madam. So thank you, Asha Jain, madam, for making a part of this webinar. So thank you, ma'am.
Thank you, Vandana, ma'am. So you have rightly said that once twins are there, most important thing is to define the chorionicity at the earliest, because it is this thing which is going to decide your consequences of the pregnancy, decide the management as well. Thank you. In spite of all technical problems, you really did a good job. Congratulations to you.
Thank you, ma'am.
And
thank you, Dr. Vandana. And it's my request to everyone. This is, a searchlight. So we are doing only the relevant clinical things, and we should try that there should be no repetition. We don't want any theory. It's basically the practical points that we need. Because if you have to speak for 8 to 10 minutes, then the whole theory doesn't work. Padma, over to you now. You will be able to share, or you want to send me a backup of your slides?
I'm sharing, ma'am. I'm sharing my screen. Good evening, madam.
Good evening. Welcome.
So coming to the next in this series, let us go ahead. Now I'd like to invite Dr. Padma Shukla ma'am to enlighten us on the topic of ectopic, that is even pregnancy at undetermined location. And it's an honor to introduce the speaker, Dr. Padma Shukla. She is MS, FICOG, FICMH. She is an associate professor. She's got special awards and achievements. She has got Best Paper Award in AICOG 2012 and 2016. She has got Young Talent Award in 2022. She has got Dr. Durusha Awardee 2022. She's got many publications on national and international journals, and she has written many chapters in the various books. She's also has been an executive editor of Pan Asian Journal. We welcome you, ma'am. Happy to have you in the series as a speaker. Over to you.
Thank you, ma'am. Thank you, Asha Jan, ma'am, for giving me this opportunity.
Thank you, Padma. Thank you, Vanna ma'am, for being here.
My screen visible, ma'am, now? Is
Yes.
it visible?
Yes. You need to make it full screen.
Yes, ma'am.
It's full screen now.
Yes, ma'am. Just a minute. Thank you, Asha Jan, madam, and thank you, Raipur Society, for giving me this opportunity. Ma'am, you have taken this topic, and that is really very useful. Pregnancy of unknown location. So I will discuss about the definition and the different tests available and what are the clinical picture as well as the treatment of the pregnancy of unknown location. The pregnancy of unknown location, or PUL, we can say in short, that it is a transient state in which beta HCG is positive, but transvaginal ultrasound fails to find an intrauterine or extrauterine pregnancy. PUL is not a final diagnosis. It is a classification that indicates the patient is at risk for ectopic pregnancy. The incidence of PUL is 8 to 10%. Biomarkers for the PUL are beta HCG and progesterone. A single serum dosage of HCG is used only to determine whether the value obtained is above or below the discriminatory zone. So discriminatory zone meaning here is that at which we can see the intrauterine gestation sac. The value of serum HCG above which an intrauterine gestation sac should be visible on ultrasound is 1500 milli international unit per ml for PVS and 3500 milli international unit per ml for abdominal USG. Serum progesterone levels are marker of pregnancy viability, but unable to predict the location of pregnancy. So when we get a case of pregnancy of unknown location, what will be the future? Most cases are low risk. Of all the cases, most of the cases of PUL are low risk and monitored by the expectant management with transvaginal ultrasound, serial serum beta HCG level, and serum progesterone level. To minimize diagnostic error and intervene during progressive intrauterine gestation, active treatment is indicated only in situations when progressive intrauterine pregnancy is excluded. There is a high possibility of ectopic pregnancy, and possibility of ectopic pregnancy is 6 to 20% in PUL cases. Localization of sac. It depends on the quality of the ultrasound, examination performed, examination experience, and the degree of resolution of the device used. Ultrasonography is the best examination method for identifying the location of an early pregnancy. Ultrasound, especially transvaginal ultrasound, identify an ectopic pregnancy with a sensitivity ranging from 87% to 94% and a specificity ranging from 94% to 99% when we do the multiple examination of TBS. But when we do the single examination, TBS has identified the ectopic pregnancy with 73.9% sensitivity and 98.3% of specificity. Common mistake is to perform TBS alone. So it is recommended that we should do the pelvic abdominal ultrasound, which will enable us to visualize the ectopic pregnancy higher in the adnexal region. A patient with a positive pregnancy test, when we do the ultrasound, there could be 5 possibilities. That is, there could be a defined ectopic pregnancy can be present, that is extrauterine gestation sac with a yolk vesicle or embryo with or without cardiac activity, or there could be probable ectopic pregnancy, means we can see on ultrasound there could be a heterogeneous adnexal mass or gestational sac-like structure, or pregnancy of unknown location, that is absence of intrauterine pregnancy or ectopic pregnancy images. Probable intrauterine pregnancy, that is presence of intrauterine echogenic gestation sac can be there, or there could be well-defined intrauterine pregnancy. The intrauterine gestation sac with yolk vesicles can be seen, or with embryo or without cardiac activity. With or without cardiac activity can be seen. So what now, as we are discussing PUL, so what is the outcome of PUL? Once we see that there is no sac in the uterus, no sac in the adnexa, then what will be the outcome? So according to outcome, there is 4 possibility. Intrauterine live pregnancy can be there, or failed PUL, or ectopic pregnancy, or persistent pregnancy of unknown location. Intrauterine pregnancy is divided into viable intrauterine pregnancy and non-viable intrauterine pregnancies. So between 30% to 47% of the patients with PUL are subsequently classified as IUP, that is intrauterine pregnancy, and viable intrauterine pregnancy denotes ultrasound sign. All of us know that there are compatible gestation age, and signs are insufficient to indicate whether the gestation is viable or not viable. Non-viable intrauterine pregnancy, in this ultrasound will show anaphoric gestation, miscarriage, or retention of product of conception. Failed PUL, that is, it is denoted as PUL-F, and there is in the failed PUL, there is spontaneous regression of the SCG level till it becomes negative. But the exact location of the gestation is never identified. Between 50% to 70% of PULs are classified as failed PUL. Intrauterine pregnancy and failed PUL, they represent the form of low risk PUL, and they are low risk for the complication as well. Ectopic pregnancy and PUL should not be considered, all the PUL should not be considered as synonym of ectopic pregnancy. Between 6% to 20% of PULs are classified as ectopic pregnancy. Then the fourth outcome is persistent PUL. In this, it occurs in 2% of the patient with PUL, and SCG doesn't decline spontaneously in this. An abnormal increase or plateau of SCG can occur. A variation of less than 15% in SCG titration over 3 consecutive 48 hours interval measurement of SCG will show the persistent PUL. Transvaginal ultrasound doesn't show intrauterine or ectopic gestation. Usually small ectopic pregnancies that are not visualized on ultrasound or represent the retention of product of conception in the endometrial cavity with an active trophoblast represent the PUL, persistent PUL. And cases of ectopic pregnancy and persistent PUL, they are considered as high risk for the complication. Persistent pregnancy of unknown location, when they are treated with the methotrexate that is administered without confirmation of location of pregnancy, because we cannot locate in this. And resolved PUL, persistent PUL is when HCG titers are negative after expected management or uterine evacuation without evidence of chorionic villi on pathological examination. Follow-up of the PUL patient. PUL is not a diagnosis. Patient should be followed up until a definitive diagnosis is made. Consensus exists regarding the definition and classification of PUL. Only valid biomarkers with clinical application and validations are serum level of beta HCG and progesterone. So come to the biomarker. First, we'll discuss about the HCG. HCG, as I told you, that discriminatory zone between 1500 to 2500 ml of HCG while using TVS. When HCG is above the discriminatory zones and no intrauterine gestation is visible on TVS, an ectopic pregnancy should be suspected. It is possible to have a viable intrauterine pregnancy even if the ultrasound doesn't show any intrauterine pregnancy and the HCG value is above the discriminatory zone. Sometimes it happens when we wait for another 1 week, we see the fact in the ultrasound. Interruption of a viable pregnancy or a malformation due to methotrexate use, interventional conduct should not be distributed based on a single dose of HCG among patients with PUL who are hemodynamically stable. Women with PUL and HCG values above 2000 milli-international unit per ml, the most likely diagnosis is a non-viable intrauterine pregnancy, which is twice as frequent as ectopic pregnancy. Most commonly used method for follow-up of PUL is a serial serum beta HCG measurement. Kadar et al. Were the first to describe that the minimum increase in serum HCG in case of progressive intrauterine pregnancy over 48 hours was 66%. An increase greater than 66% in a HCG titer at 48 hours is highly suggestive of viable intrauterine pregnancy. A decrease in HCG titers indicate a non-progressive gestation, and an HCG ratio of 0.87% suggests a failed PUL with a sensitivity of 92%. HCG titers increases by 66% or decreases by 13%, then the possibility of ectopic pregnancy or persistent PUL increases. In 15 to 20% of ectopic pregnancy, the titers, HCG titers over 48 hours, they are similar to progressive intrauterine pregnancy. So there could be 66% increase of the HCG titer in these cases, in 15 to 20% cases. In 10% of ectopic pregnancy, they show the HCG behavior at 48 hours similar to those of failed PUL cases. Sensitivity of HCG ratio. HCG ratio means HCG at 48 hours, after 48 hours, and HCG at 0 hours. So to HCG ratio, sensitivity of HCG ratio to predict an ectopic pregnancy range from 74% to 100%. Other conditions for elevated beta HCG are ovarian cyst, teratomas, gestational trophoblastic disease, non-gynecological sources of elevated beta HCG. So we should keep all these conditions in our mind as well. Other biomarker for PUL is serum progesterone. Serum progesterone level are a satisfactory marker of pregnancy viability. They are unable to predict the location of PUL. Progesterone level below 5 nanogram per ml are associated with non-viable gestation, and progesterone level above 20 nanogram per ml are correlated with viable intrauterine pregnancies. Most ectopic pregnancy present with progesterone level between 5 and 20 nanogram per ml, which limits its use in clinical practice to exclude the possibility of ectopic pregnancies. Serum progesterone levels are useful to identify patients with failed PUL. There is one new biomarker for PUL, that is inhibin A. Inhibin A level is significantly lower in cases of PUL that resolves spontaneously compared with the cases that result in ectopic pregnancy and intrauterine pregnancy. So lower inhibin A can be used as a biomarker for PUL. Prediction of outcome. There are two models which was given. They are the logistic regression model. M4 model to predict outcome of PULs as well as minimize the examination and follow-up of patient and classified as low or high risk. It is based on the HCG ratio and to calculate outcome and classify patients. Insertion of the HCG values in the M4 model calculate the risk of PUL cases that results in ectopic pregnancy, intrauterine pregnancy, and failed PUL. This model classifies pregnancy of unknown locations as low risk if the estimated rate of ectopic pregnancy is less than 5%, and as high risk if the estimated rate of ectopic pregnancy is more than 5%. So, according to this follow-up of the low risk cases, that is ectopic pregnancy risk is less than 5%, cases performed with a urine HCG test in 2 weeks or TVS transvaginal sonography within 1 week. But in high risk cases, the serum level of HCG measured and ultrasound is performed, TVS is performed every 48 hours. So this is for follow-up of the patient. Another model is model 6P, that is polynomial logistic regression model, and it involves two-step tests. Initially, we do progesterone, and progesterone level is performed. If the progesterone titers are 2 nanomole per liter, the patient is considered low risk, and follow-up is performed via urine HCG test in 2 weeks. In case of progesterone level 42 nanomole per liter, the second test that examines the HCG ratio. So we have to go for, once the level is high, then we have to go for HCG ratio. If patient uses progesterone supplementation, then test employs a variable. Similar to the M4 model, if ectopic pregnancy risk is more than 5%, then the case is considered high risk. If ectopic pregnancy risk is less than 5%, then case is considered as low risk. In high risk patient, again we have to do the HCG, serial HCG and TBS every 48 hours. Clinical presentation of PUL, most of the patients, they are asymptomatic. There could be pelvic pain, vaginal bleeding, along with the positive pregnancy test. Investigation, as I told you that the chances of ectopic pregnancy is in 8 to 40% or up to 20% of cases. So before a final diagnosis can be reached, patient require multiple visits, frequent testing and consistent follow-up until the location and the viability of the pregnancy are determined and definitive management is performed. A systematic review and meta-analysis of diagnostic protocols for the management of PUL demonstrated that the M4 model was the best available method for predicting the outcome of ectopic pregnancy. Initial serum beta HCG and the 48 hours beta HCG ratio were used to measure the primary outcome, which was an accurate predictor of ectopic pregnancy. an expectant approach to PUL is considered. Most cases are low risk and can be monitored by expectant management with transvaginal ultrasound and serum HCG level in addition to serum progesterone level. Treatment. The laparoscopy is reserved for the cases of PUL with the symptom or sign of hemoperitoneum. Uterine evacuation is being done at United States by DNC, or basically they prefer MBA, to differentiate ectopic pregnancy from non-viable case of intrauterine pregnancy. The logic behind this evacuation is that the non-viable intrauterine pregnancy might be associated with recurrent miscarriage requiring further investigation. Another favorable point for uterine evacuation is that unnecessary use of methotrexate would be avoided in up to 50% of cases. Presence of chorionic villi in evacuation material is used to diagnose non-viable intrauterine pregnancy. Perform serum HCG test immediately when they do the evacuation. The serum HCG level is done immediately before uterine evacuation and 24 hours afterwards. If the HCG titers they are decreased by at least 15% after uterine evacuation, diagnosis of a non-viable intrauterine pregnancy will be followed. If serum level of HCG is stabilized or increased, then the most likely diagnosis will be ectopic pregnancy and patient will be treated with the methotrexate. But this is what we have to keep in mind, that in case of PUL, uterine evacuation should be an exception and only performed after the possibility of a viable intrauterine pregnancy has been excluded. This is the latest recommendation. Then use of methotrexate in the treatment. Persistent PUL cases of clinically stable patients presumed to have ectopic pregnancies. We can use methotrexate. Depending on the patient preference, methotrexate can be offered as an alternative to uterine evacuation. This drug is antagonist of folic acid and shows a high success rate in the selected ectopic pregnancy cases. A 50 milligram per meter square dose of methotrexate is injected intramuscularly, and if HCG does not decrease by at least 15% between days 4 and 7, then the same dose of methotrexate is repeated. Before initiating methotrexate treatment, it is essential to test for normal complete blood count, urea, creatinine, and liver enzyme tests. Similarly, like uterine evacuation, before administering methotrexate, one must ensure that the progressive intrauterine pregnancy is not present. Counseling of the patient is also very important. Once we deal with the cases of PUL, we should counsel the patient about the fate of the PUL, and we should tell her about the possibility of an ectopic pregnancy, and she should quickly seek care in the event of its sign and symptoms. Take home messages. Women with PUL should be followed up until a final diagnosis is established. In addition to transvaginal sonography, routine abdominal pelvic ultrasonography for the complete visualization of the adnexia is mandatory. Most cases are low risk and can be monitored by the expectant management with transvaginal sonography and serum HCG level, and in addition to serum progesterone level. Thank you for patient listening.
Thank you, Dr. Padma. You very wisely and covered everything, including the importance of not only transvaginal ultrasound but also the transabdominal one. Very rightly covered, very nicely, very good talk. Coming towards
Thank you, ma'am. Thank you so much.
Coming towards the another last speaker, that is Dr. Rashmi Sharma. I'll invite Dr. Rashmi Sharma to throw some light on vesicular mole. Dr. Rashmi Sharma, can we have her CV, please? She is
Padma, please stop sharing.
Yes, ma'am. Yes.
Yeah, I'm Dr. Monica Pathak from Raipur, Secretary, Raipur Society. Welcome, Dr. Rashmi.
Yeah, good evening, everybody. Good evening, everybody. First of all, I must thank Dr. Asha Jan for inviting me for today's session. I'm really thankful to you, ma'am. I've started sharing. Is it visible?
Yeah. Before that, let me introduce you to everyone. Dr. Rashmi Sharma, she's a consultant, Apollo Hospital, Bilaspur, and she has got her special interest in laparoscopic surgeries as well as cosmetic gynecology. Right now, she's President Foxy Bilaspur. We welcome you, ma'am.
Thank you, Dr. Monica. My slides are visible to you?
Yeah. No, right now, no.
No. आशा मैम
Yes.
आशा मैम को कुछ करना होगा आपको
अभी करती हूँ.
Asha ma'am, there is a call from labor room. I'll join very soon. I'll come back and join you all.
All right.
Sorry. I'll join in short while.
Is it visible now?
Yes, it is visible. So you don't need me.
Yeah.
It's done.
So gestational trophoblastic disease refers to heterogeneous group of interrelated lesions that arise from abnormal proliferation of placental trophoblast. And they include both benign and malignant lesions. Benign lesions are complete herpetiform mode and partial mode. And in malignant lesions, it is invasive mode, placental site trophoblastic tumor, and epithelioid trophoblastic tumor, and choriocarcinoma. Today we will talk only on benign conditions, that is herpetiform mode. Its incidence in UK, all GTD cases are nationally registered with Central Pathology Review. So the incidence, they know it is for complete mode, it is 1 to 3 per 1,000 pregnancies, and for partial, it is 3 per 1,000 pregnancies. And in our country and Asia and North America, it's more frequent in our country, in Asian countries, rather than in North America or Europe. What are the risk factors for herpetiform mode? It is advanced maternal age, very young age of conception, previous molar pregnancies increases chances by 2 to 10%, blood group A, and there is decreasing consumption of protein and animal fat, oral contraceptive, folic acid vitamins use have also been implicated in having higher incidence of herpetiform mode. There is a short comparison between partial and complete herpetiform mode. Its instance I already told you. And karyotyping, it complete, it is diploid, and in partial, it is triploid. And in pathology, fetus and embryo are absent in complete form, complete molar pregnancy, and it is present in partial molar pregnancy. Amnion, fetal erythrocytes are also absent in complete molar pregnancy, and it is present in partial. Villus edema is diffuse in complete molar pregnancy, and it is focal in partial. Trophoblastic proliferation is marked in complete molar pregnancy, and it is focal or minimal. Then trophoblastic epithelium is marked in complete molar pregnancy, and it is mild in partial molar pregnancy. On immunostaining, P57KIP2, it is negative in complete molar pregnancy, and it is positive in in partial molar pregnancy. On clinical examination, when we do uterine size assessment, it is large for dates for complete molar pregnancy, it is small or corresponding to dates of gestation in partial mole. Fecal uterine cells are present in 25 to 30% of cases in complete molar pregnancies, whereas it is absent in partial. Initial HCG levels are more than 1 lakh in complete molar pregnancy, and it is less than 1 lakh in partial molar pregnancy. And progression to GTN is more common in complete molar pregnancies, and it is less than 5% in partial mole. And progression to choriocarcinoma is 3% in complete molar pregnancy, and it is less than 0.1% in partial mole. On clinical findings, these days, because of universal use of ultrasound, classical findings are missing, but still irregular vaginal bleeding is the most common presenting features, which varies from spotting to profuse bleeding, and sometimes they give history of passage of grape-like vesicles also. Then positive pregnancy test and supporting ultrasonic sonographic evidence, these three, they really clinch the diagnosis of molar pregnancies. The less common presentation of molar pregnancies include hyperemesis, excessive uterine enlargement, signs and symptoms of hypothyroidism, then early onset of preeclampsia, and abdominal distension due to fecal uterine cyst. Uterine enlargement is larger than expected for period of amenorrhea, usually in the cases of complete molar pregnancy, and it has got soft consistency and no fetal parts or hard sounds are detected in them. And hyperemesis is due to high levels of beta HCG. Fecal uterine cyst results from overstimulation of uterine elements by HCG, and usually they regress following evacuation of pregnancy. So we should do expected management in such cases. But sometimes cysts may undergo torsion, hemorrhage, or infarction occasionally. In that cases, we have to manage case to case wise. In differential diagnosis, we have to think of threatened abortions, missed abortions, fibroid with pregnancy, and multi-fetal pregnancy. Usually, they come in differential diagnosis of partial molar pregnancies. Now, what are the complications? Usually, they may land up with excessive bleeding and hemorrhage with severe anemia, preeclampsia or eclampsia, acute respiratory distress because of embolization of prophylactic tissues. Then sometimes the molar pregnancy keeps on bleeding, and then that may lead to uterine perforation, infection, DIC, and thyroid storm. For diagnosis, we must have beta HCG measurements. Usually, it is very high in complete molar pregnancy, and it's not so high in the partial mole. In ultrasonic examination, in complete mole, we usually see snowstorm appearance. But in partial mole, it has features that include thickened multicystic placenta along with some fetal tissue. Ratio of transverse to AP diameter dimension of gestation sac of greater than 1.5 along with thickened multicystic placenta is highly suggestive of partial mole. In histopathology, it is difficult to distinguish between early abortions, partial and molar pregnancies on the basis of just clinical, radiological, or histological characteristics alone at times. So in that cases, combined analysis of ploidy analysis and P57KIP2 staining are helpful in arriving at diagnosis. So the different scenarios that point toward diagnosis are for complete mole, diploidy is there, and P57KIP2 is negative. While in partial mole, it is diploidy pregnancy, and P57KIP2 is positive. For management, like in any other case, we have to do pre-operative evaluation that should include all the investigations to identify medical complications like preeclampsia, hypothyroidism, anemia, chloride depletion from hyperemesis, and metastatic diseases. So they must have blood grouping and RH typing, the hemogram to know the status of her anemia, and liver and kidney function tests, serum thyroid level, and chest X-ray should be done as baseline investigations. CT and MRI are reserved for patients showing metastasis on chest X-ray or elsewhere. And blood should always be cross-matched, arranged, and patient party must be informed, and written consent should be taken for need of blood transfusion. And for termination of molar pregnancy, suction evacuation is the most desired treatment. And medical evacuation are done sometimes in partial molar pregnancy when there suction evacuation only. Oxytocic agents are not routinely used because of the potential to embolize and disseminate trophoblastic tissue through the venous system. And we must have IV access, adequate anesthesia should be there, and blood, as I said, blood products should be arranged before going for suction evacuation. Cervical priming to be done when the cervix is not right. In that cases, we must prime the cervix because we have to allow insertion of 10 to 14 millimeter of suction fluid. And usually, they don't recommend prolonged preparation of cervix with prostaglandins because there is a chance of dissemination of trophoblastic tissue. Oxytocin may be infused with the beginning of suction to limit bleeding. Usually they recommend when the about to complete, when the suction evacuation is about to complete, in that case, oxytocin, in that time, oxytocin should be given. But at times when there is bleeding, profuse bleeding in the beginning of the suction, then that time one must start oxytocin infusion. And suction may be done, and it's best to do the suction under ultrasound guidance. And we may come to know about the completion of the procedure. And in that case also, suction cannula is not needed to be moved here and there in the uterine cavity, because the placental tissue there come on its own when the suction cannula is inside the uterus. If bleeding continues despite oxytocin, methergine, carboprost, or misoprostol may be used. And sometimes uncontrolled bleeding may require pelvic arterial embolization or even hysterectomy. One has to resort for it. Anti-D should be administered to Rh negative women because fetal tissue in partial mole may include RBCs and D antigen. Complete molar pregnancy, they don't have RBC and the fetal parts are not there, so they don't need anti-D. But we come to know the definitive diagnosis of partial, whether it is partial or complete. It is done only after the pathological evaluation, and it may take time. So it is good to give anti-D to all the molar pregnancies post evacuation. Sometimes we have to resort to hysterectomy when the family is complete and when there is intractable hemorrhage and the bleeding is not being controlled and you don't have access to arterial embolization. In that case, we may go for hysterectomy, though it is very rare these days, and only when the cervix is not ripe and family is complete, we go for it. And while doing hysterectomy, there is no need of doing surgery for thecal utensils because they resolve spontaneously. Post-evacuation surveillance, patients need to be under close surveillance after the evacuation of the gestational trophoblastic disease, that is molar pregnancy. It is done by serum beta-HCG monitoring. First assessment should be done after 48 hours. Then after that, it is done weekly till 3 consecutive tests are negative. Usually it is by 7 weeks for partial molar pregnancy, and it is 9 weeks for the complete mole. And after that, it is done monthly for 6 months. During the surveillance period, the patient is asked to have to practice some contraceptive method, and it is good to have combined oral pills, and they are not advised to have IUCD, and they may use barrier method or combined oral pills. This is a short chart of the management of H-bole, which I have already detailed. While starting the case, we take the history, we do examination, do ultrasonography, and follow with the beta-HCG and do the baseline investigations. Then you assess the case. If the cervix is open, you start with the IV drip, and you start the procedure of suction evacuation. And when the cervix is closed, one must prime the cervix with misoprostol, danroprostol, or levodopa. And if the cervix is not dilated, then one may go for hysterectomy. And hysterectomy is very rare these days. And hysterectomy is done in selected cases like elderly patients, and perforating mole is there. When there is intractable bleeding. And the usually follow is up for 6 months. Thank you.
Thank you, Rashmi Sharma ma'am, for this insightful presentation. This presentation helps our audience with your valuable knowledge and on molar pregnancy. And you have covered all the points very precisely. Thank you so much. In such a short time. Thank you so much.
So thank you, chairpersons, Monica, Tabassum, and Sangeeta, for being here. And thank you all respected speakers, Dr. Nidhi, Dr. Vandana, Dr. Padma, and Dr. Rashmi, for actually taking care of the topics. I realized one of my mistakes, that I needed to be a bit more precise in giving topics, because we want only one aspect covered. It's a searchlight. So if it is more precise, it takes less time and it gives more take-home messages. So I think it's a good learning for me for next time. And now it's time for the panel. If our dear chairpersons would continue, I would be grateful. And we start the session now. So this then is the panel. I would request all panelists, please put on your videos so that we can see you. Yeah, thank you. Thank you, Dr. Sunita. I have not assigned questions to anyone. You're free to take the questions yourself because you've already heard all the theory. Now we are just going to recap what we remember of it. You know, when a patient has come to us, how we are going to deal with it. So this is the Searchlight on first trimester bleeding. My spiritual mentor, Swami Anubhavananji, says, everything that we know is only an excuse by which we should reach the unknown. So whatever we know, we are trying to know more and reach there. So with that, that's me, and I've been introduced and you know me. And these are my respected panelists. We have Dr. Kirti Kaura, who's the Secretary of Bhilai Society, Dr. Nidhi Mishra, past President of Sagar Society, Dr. Rekha Singhal, who's the Secretary of Riva Society, Dr. Dolly Mehra, past President Ratlam Society, Dr. Sunita Vadvani, President Ratlam Society, Pratibha Makhija, who's the Secretary of Bilaspur Society. I request you, please put on your cameras so that I can see you, and everyone is welcome to pitch in. So this is a chart that you've already seen. You have threatened abortion, inevitable abortion, complete abortion, incomplete abortion, and missed abortion. And it is all basically a sonographic diagnosis. Dr. Nidhi explained this really well. Now we'll just go to the situation. Now the situation is such that there's a lady who's been married for 2 years, gravida 1, para 0, comes to the clinic with amenorrhea of 7 weeks. She has a history of regular cycles with bleeding per vaginum and mild pain in the back for the last 6 hours. Whole family has come and everyone is in a panic mode. What are you going to do?
We'll take the proper history of the patient, ma'am.
Yeah.
And then go advise a sonography for her.
So, you know, this is very important that the whole family is a panic mode. So what exactly are you going to do? I want every panelist to pitch in. You know, you can add your ideas. It doesn't have to be just one person.
We can counsel them regarding physiological bleeding also. We can counsel that there are chances that a lot of pregnant people, they can get a little bit of spotting, but it is not not to worry so much. So we can confirm the fetal heartbeat by doing an ultrasound, and that will decrease their panic. So we can do that. We can do the counseling. We can advise them ultrasound investigation.
Madam, we can do a baseline per spectrum examination, so that if there is some vascular lesion or some local lesion, we can rule out. And definitely transvaginal scan will help us to decide further. So many, like we have to do a counseling. Once the scan is done, we can counsel for basically for other viability of the fetus and other things, depending on the scan.
So I would like to add one more thing here, along with the routine investigations which we are going to do for an antenatal patient. We will also get her beta HCG level done so that we can repeat the beta HCG level after 48 hours. And then at that time, we can just convince the patient that yes, the beta HCG level is rising and the pregnancy is moving towards the right side.
So what are you actually going to counsel her, and what is the specific counseling that you're going to do? They are all in a panic. They're sitting on your head, she's bleeding, she has pain. What are you going to do? What
Madam,
is the content of your counseling?
Yeah, we have to explain them that even if it is a threatened abortion, there are fair chances that she will continue further her pregnancy with proper vaginal support and count. Okay, and if there is even patient with 4 abortions, they still have a 45% chances of having a live birth rate. So this counseling is a must regarding to the couple and the family members. Like there are less chances of abortion, and there are more chances of live birth.
Okay, and now what about the investigations? Dr. Dolly said she would like a beta HCG. What other investigations do you want?
All the routine investigations which we get for an antenatal patient, like the CBC, the sugar levels, the HIV status, the glucose screening test, the thyroid status, urine examination, all that has to be done for this patient.
Okay, now you ask for basic investigations, including the blood group, thyroid, sugar. You also advise a scan. A scan is done, and there is a 300.5 cc sac, which is intrauterine, with a fetal pole of only 5 millimeter, no cardiac pulsation seen, and there is a right corpus luteum, and there is a little free fluid in the lower uterine area.
It's absolutely normal for a 5 millimeter fetal pole that we don't see the cardiac activity. We will wait till we see a cardiac activity once the the pole becomes 7 mm size. 7 mm is the cutoff at which we should see the cardiac activity. So a repeat scan has to be done after, say, around 1 or 2 weeks, according to the beta HCG levels.
Yeah, we can correlate with the beta HCG levels.
Anything else? What are you going to, again, we come back to the question, what will you reassure them? She has a little bit of bleeding. We know that this pregnancy might or might not continue. How will you counsel? And then they ask you that you are not able to tell that this pregnancy is good. So what is the need of the test? What will you say?
Actually, positivity of the patient and the positive attitude of the patient's relative is a must during pregnancy, because psychology also plays a very major role in continuing the pregnancy. This is how you need to counsel the patient and their relatives, and it is usually effective.
Support of the family is important for the patient. So the relatives also have to be counseled that they should have a positive mindset so that they can counsel the patient accordingly.
And as we say that tender loving care is very important for these patients. So telling them that we will get to know after the next beta HCG level or the next sonography whether this pregnancy is going to go towards the right direction or there will be some trouble. So at present, there is nothing to worry. You continue with the pregnancy, relax, continue, take the medicines, and just wait and watch.
And it should be positive and negative, both counseling. Patients should not be said only positive things about the pregnancy. Otherwise, later on, they come to you and tell you that aapne to bola tha ki everything is fine now. The things have gone in a wrong way. So you need to do it either ways.
So that is a very important point, that we need to keep a positive attitude, but the counseling has to be positive and negative. That is very correct, Dr. Sunita. And now, when do you want to repeat the scan?
At least 2 weeks.
15 days.
Yes. Would you want to wait for 2 weeks? It's 5 mm.
7 days. 7 days is fine. But the patients
No, we will do a beta HCG.
Yes. How often?
After 48 hours and see the doubling.
What is the minimum increase that tells you that there's a viable pregnancy?
66%.
Okay. So would you repeat in a week? You are all saying no.
It has to be 2 weeks.
Minimum
The scan has to be 2 weeks.
Or a minimum of 11 days.
Yeah.
That is as per NICE guidelines. Okay. So now This is another situation that the scan was done and there was an extra uterine gestational sac seen in the right adnexa with a fetal pole with cardiac pulsations. There is some intrauterine fluid with low level echoes. There is also fluid collection in the pouch of Douglas. What is this?
Ectopic pregnancy.
Ectopic.
Right-sided ectopic pregnancy.
Unruptured ectopic.
See here, madam, if you know what I mentioned, that if we do a beta HCG level, repeat a beta HCG level, if there is a rise of more than 66%, it would majorly confirm that the pregnancy is good and intrauterine. If the rise is between 50 to 66%, that means there is some issue, there can be ectopic. And if the rise is less than 50%, that means this pregnancy is not going to move ahead.
But ma'am, this pregnancy is on the ultrasound. This is showing an ectopic pregnancy. So this is a confirmed ectopic.
Activity is already there, ma'am.
Yeah.
In the ectopic.
So now what is your counseling going to be?
We need to explain the patient what is ectopic pregnancy. We need to tell them what actually is the ectopic pregnancy, and we should counsel them that this has to be terminated.
And the types of treatment also, we have to counsel them regarding medical management and surgical management.
I want each one of you to tell me what would be your preferred mode of treatment and why.
Madam,
we start with you. Yeah, Pratibha, we're coming to you.
Yeah.
Dr. Nidhi, what treatment would you prefer and why?
Ma'am, this is an unruptured ectopic pregnancy. And so we can go for medical management, and it is a small gestational sac. We can
But you are already seeing cardiac pulsation.
Yeah, cardiac activity is already seen, so we cannot go for.
We cannot go for medical management.
Pratibha?
Madam, because it is cardiac pulsation, I would just check the beta C level, but definitely I will go for the surgical management. I won't go for that medical management in this case. And there is also free fluid also a collection seen in the pouch of Douglas. So the preferred mode will be laparoscopy in this case.
Laparoscopy.
Dr. Rekha?
Ma'am, laparoscopy, salpingectomy.
Again, we come to salpingectomy or salpingostomy.
It's a very difficult thing to answer. Actually, we have to again explain them that if we go in for salpingostomy, then there is a chance of repeat ectopic. If we go in for salpingectomy, then chances of ectopic from this tube will be minimal.
Okay. See, these days, many patients, once you take out the tube, they have it in their head that that ovary is now wastage. So many patients will come to you. I have a patient who repeatedly says, my left tube is gone, so I cannot conceive from my left ovary. What is your experience about it, Pratibha?
Yes, madam. Often they come, but I always check the other tube and I write my notes in the discharge ticket. See, and always have a positive counseling for the patient that with another tube also you can conceive, and many patients conceive also. The proper counseling is very much for these women.
Okay. Dolly, you want to add something?
Yeah, ma'am, it's they have to be properly explained, and a consent has to be taken for a salpingectomy, even if it is laparoscopic or salpingostomy, mentioning that there can be a chance of repeat ectopic if we go ahead with salpingostomy. And they can also be counseled regarding the use of IVF pregnancy. This ovary is functioning, and she can very well go ahead with an IVF conception.
Right.
Madam, we can, if there are, like, once we put the laparoscope, and if it is like in the tubal abortion case, and it is not unruptured, then we can do self-injectomy for and counsel them. And if it is really ruptured, then self-injectomy is the best for them.
Okay. Okay. So, Dr. Nidhi, would you like to add something?
Ma'am, you were asking that the patients say that their ovary is also not working. So we can counsel them regarding that we have removed the tube, but both the ovaries will be working. So ovulation can be there from both the ovaries.
No, that is what they say, that it is a wastage because there is no tube to take the egg.
Yeah, that is what the patients say usually.
So we are done with an ectopic, and this is the image that you see. And then we have the guidelines. So these guidelines have been shown again and again. I don't think I need to show it once more. They've been discussed in great detail. So if you have a heartbeat, you're going to go ahead and do a surgery.
Surgical management.
But if you do not see a heartbeat, then Dr. Padma has explained it very well. I want one of the panelists to actually put it in short, in a 2-3 lines.
That medical management.
Yes.
Methotrexate.
When? At which level of HCG are you going to put it?
Ma'am, less than 1500 IU. International unit.
I'm a compliant patient, beta HCG level less than 1,500 international unit, and the mass less than 3.5 centimeters.
Okay. Okay. Any addition anybody wants to do in this?
Cardiac activity should be absent.